Good evening, everyone, and thank you for joining us. My name is Adrienne. I'm a product specialist at Oculus. Welcome to our clinical webcast titled Ladies of Contact Lenses, Scleral and Ortho-K Troubleshooting with the Oculus, Pentacam, and Keratograph. Please remember you have a text box on your GoToWebinar screen where you can enter questions throughout the webcast. Time permitting, we're going to try to answer a few questions in between each presentation. If we don't have time to answer a question, we'll be happy to respond via email following the webinar. We're all very excited to have an all-women's case review panel tonight. I would first like to introduce Dr. Daddi Fadel. Dr. Fadel is a clinical scientist at the Center of Ocular Research and Education. She is internationally recognized as a KOL and actively lectures in 5 languages. Dr. Fadel is a pioneer of modern lens design and a specialist in contact lenses for irregular corneas, scleral lenses, myopia control, and orthokeratology. She is also the author of the book titled Scleral Lens Complications, Their Recognition, Etiology, and Management. Next, I would like to introduce Dr. Cheryl Chapman. Dr. Chapman is a graduate of the University of Houston College of Optometry and currently works in private practice in Gretna, Nebraska. She is serving as an adjunct assistant professor at the University of the Incarnate Word Rosenberg School of Optometry. Dr. Chapman has instituted a full-scope myopia management clinic with her practice and works tirelessly at spreading myopia management knowledge. We're also happy to have Christine Sindt with us tonight. Dr. Sindt graduated from Ohio State University of Optometry. She joined the faculty of the University of Iowa Department of Ophthalmology and Visual Sciences in 1995, where she is currently the Director of Contact Lens Service and Professor of Clinical Ophthalmology. Dr. Sindt holds 7 U.S. patents and has over 150 publications. Finally, I would like to introduce Dr. Jamie Kuzniar. Dr. Kuzniar received her doctorate of optometry from Michigan College of Optometry at Ferris State University. She is the owner and founder of Elevate Eye Care and Eyewear in Rochester Hills, Michigan. Dr. Kuzniar is a fellow of the Scleral Lens Society, as well as the American Academy of Optometry, and is on the advisory board member for GPLI. We will now start our case review with Dr. Fadel. Dr. Fadel?
Thank you for the introduction and thank you for having me. Okay, so yeah, we've been using technology to customize contact lenses for years now, and we noticed that what we were customizing is the patient's care, not only the contact lens design, because technology allowed us to better educate our patients through photos, topographies, graphs, and lens designs, and all these features allows us to ameliorate our communications with patients, increasing empathy and compliance, and consequently, lens fitting success was improved as well. Not only because of the lens design, the customization of the lens, but just because of the empathy, the education, and the compliance, they were improved. So today I will show how technology is breaking borders, connecting peers between continents, and helping patients all over the world to get highly customized contact lenses, specifically scleral lenses in this lecture. So next, please. Why is crucial to connect with peers in other countries? Because patients from all over the world are searching for customized lenses, and these are messages that I receive from patients all over the world, and they are not asking me if I fit scleral lenses, but they ask me what technology I use to fit scleral lenses, and sometimes they ask for a specific technology they want to be used for their lens fitting. Some of these patients could come to my practice in Italy and have the customization of their lenses with the technology they were asking for, but some others couldn't come because of financial limitations or visa issues. And every time a patient couldn't come, I was very disappointed and I wanted to help them in somehow. So I couldn't travel everywhere to fit them, also because they needed to have a follow-up, and I couldn't travel frequently to those countries to make the follow-ups as well. But what I could do is to travel to several countries and teach practitioners how to fit scleral lenses so they could help these patients and have regular follow-ups with these patients. Also because when I used to fit international patients, indeed follow-ups were an issue because these patients could come for the lens fitting, but they couldn't spend further money to come back for the regular follow-ups. So every time I had to search for a local doctors to follow up with them and understand if the fitting is still good or needs some changes. Also because the ocular surface has some changes with time. So local doctors who know how to fit scleral lenses are essential, not only how to fit scleral lenses, but also doctors who have technology to fit scleral lenses are essential. Otherwise, their patients will continue to travel to get the technology they are asking for. So it's not enough to fit any more scleral lenses, but it's important to fit scleral lenses with some technology because patients are asking for this. Next, please. So in my project that I founded in teaching practitioners how to fit scleral lenses in different countries, the first country in 2022 was Ireland. And in Ireland, I had my contact, Kian Gildea, who is an optometrist, an Irish optometrist, who helped me in the organization of the workshop. And he brought to the workshop 2 patients. One of these patients was a 33 years old man, and he had keratoconus. So here you can see his parameters of the keratoconus. They were not special. It was a mild keratoconus. And here you can see the topography, the corneal topography of his eyes. So the keratoconus was not special, but what was special in this case is this huge toricity he had in the sclera. So that's why all the lenses that he was wearing, they were all decentered because of the huge toricity. So in this case, you can see that the sclera was indeed toric. It wasn't asymmetric, quadrant specific, but toric and with the rule toricity, with the steepest meridian, the vertical one, and the flattest meridian, the horizontal one. And the toricity in his right eye was about 950 microns, and in the left eye was about 720 microns. During the workshop, we had the Pentacam CSP. So during the workshop, we performed the corneal scleral profile. And after the workshop, Kian performed the over-refraction and sent me all the details, also the details of the lens with which he did the over-refraction, which are base curve and the power of the lens. And based on this information, the CSP and the over-refraction, I designed the lenses for him. Next, please. And here you can see the design of this lens, the difference between the design in the horizontal and the vertical meridian. The clearance was totally different, and also lens alignment was different. The sagittal height between quadrants was totally different. There was a huge difference between the different quadrants. Here it's very small, you cannot read it, but in the next slide, you can see how much difference he had in the 2 opposite quadrants in every semi-quadrant. So here you can see between the nasal and the temporal, he had 932, between the superior nasal, inferior temporal, 1,107 microns. But if we consider the lowest and the highest sagittal height in this lens design, it was about 1,600 microns. Next, please. So these lenses were shipped from the lab from the UK directly to the practice of Kian Gildea. Next, please. Next slide. And these lenses were applied on the eye. I never saw these lenses. I never saw the patient because this is not my patients, it's Kian Gildea patients. I only assisted in fitting this patient. And Kian sent me this picture to show the huge toricity of the lens. And this is the lens applied on the eye. And if you remember, the difference between the greater difference was between the nasal and the inferior part of the sclera, and here you can see how the lens was well aligned in these 2 quadrants, and the lens centration was optimal in this case as well. So for the left eye, similar thing, the clearance and the lens design was totally different in each quadrant. Here you can see the difference between clearance in the horizontal and vertical meridian. Next, please. And here again, with the report, you can see the difference between the two opposite quadrants. But again, if you consider the highest and the lowest sagittal height, you will see that the major difference was between the nasal and inferior temporal. And in this eye, it was about 1000 microns. Next, please. So here the OCT performed by Kian again shows how in these two quadrants the lens was well aligned without compression and without edge lifting. And here you can see the lens evaluation with the slit lamp, and you can see the nasal area, the temporal area, and the inferior area. Again, the lens is well aligned, the centration of the lens was optimal. The patient was very happy because comfort was increased compared to his other lenses, which were always decentered and moving. And also the visual acuity was optimal. Next, please. So these lenses were the first lens delivered and the final ones. I didn't have to make changes and resend other lenses because the fitting was very good and the over refraction was plano. So here you can see the visual acuity with scleral lenses, how scleral lenses ameliorated visual acuity compared the best corrected visual acuity with spectacles and unaided visual acuity in both eyes. So over refraction was plano. First lenses delivered to Kian were the final lenses. This is a case in Singapore. It's an ongoing case. We are still working on it. So this patient had to choose between two options. One, travel to the optometrist he wanted to go to and get scleral lenses, or stay in Singapore and invest the money in customized scleral lenses. So the optometrist following him was Savita Kumar, and Savita contacted me to assist her in customization of the lenses. So we decided to keep the patient in Singapore and let him invest, help him investing in his lenses instead of spending money traveling. So again, here the keratoconus was moderate. Next, please. And there is no special, next slide. Okay, here you can see that the corneal topography is a moderate keratoconus, and also the sclera in this case is not special. He has a normal toricity, but again, the patients wanted customized scleral lenses, so why not to provide him with what he's asking for? So I'm waiting for, we have the CSP report to design the lenses. I'm waiting for the U12 file and the over refraction and the details of the contact lens. And then I will design the lenses. And again, here the lenses will be shipped from the US directly to the ophthalmologist who is following the patients in Singapore. And Savita from India is also following up with him with the design. So they will send me the pictures after lens application, and we will assess the lens fitting. If there is any changes to do, we will be performing changes. So these cases demonstrate how technology has the potential to revolutionize the fitting process between peers, enabling optometrists to provide assistance and experience across the different countries and different continents. Next, please. And the use of remote fitting technology allows also tending your arms and hands, and your arms and hands are helpful in another country, in another continent. And this is helping connecting optometrists around the world. And also what I noticed by remotely designing the lenses and discussing the case with the eye care professional, it's also possible to educate peers, to educate that practitioners in far-off locations on specialty lenses and how to customize these lenses. So remote fitting also allows patients to invest in their health and receive quality care instead of spending money in travels and hotels. And more important thing is that remote fitting can be a safer option for patients, because again, many may be able to come for the fitting, but may face challenges returning to the optometrist practice for the follow-ups optometrist. And we know how follow-ups are essential in some cases, especially for patients with compromised cornea, and regular and close follow-up for these patients are important. But sometimes they cannot come back for the follow-ups because, again, for financial limitation or other barriers or visa again. So having some local practitioner, local doctors who is following up with these patients is important, and also not only following up, thinking that fitting from the beginning to the end. So assisting local doctors is essential for providing optimal care for patients and to maintain the corneal health of these patients all over the world. So I think it's time for practitioners who want to expand their expertise. It's time to expand our capacity in helping patients and practitioners in their own countries. I think we can create, I don't know, maybe some CSP WaveNet in changing life. Thank you.
Thank you so much, Dr. Fadel. If we could move on to our next presenter, Dr. Chapman.
Thank you so much for having me. And that was a really wonderful case study. I appreciated being able to watch that. Today, I have two cases that I would like to present, and they're both Ortho-K cases. So let's go ahead and start with the first one. Go ahead and fast forward. All right, so the first case here is a steep cornea. And so we've got a little 6-year-old girl here, Asian female, high risk for progression. She's already nearsighted. And one thing I like to do is check the vision unaided, because that gives a lot of wow factor. And you can see that her unaided acuity is 2150. She also has a fairly low prescription in terms of Ortho-K. You would look at this generally and think, oh, well, this isn't going to be too difficult at all. There's not a lot of toricity, pretty low myo. All right, so this is what her format refractive looks like with the Pentacam. And if you look at the bottom right scan there, you'll see that is our elevation. I'm sorry, that's the back surface elevation. So I like to use that to kind of screen for keratoconus. And you can see the top right map is her front surface elevation. Go ahead and fast forward to the next slide. This is a tangential topography. And when you look at this, you see that red band across the top. She was very steep superiorly, actually, and I have two different topographies in my practice, or two different topographers in my practice, and so I confirmed this by measuring it with placido-based topography as well as the Pentacam, and I took 4 scans of each eye, and it just kept coming back this way. So that led me to believe that she really is more superior, or more steep superiorly in this cornea. And her other eye is actually quite similar too. She just has really, really tight upper eyelids. Remember, she's Asian, and that can be common in that population. So you'll see here with the Pentacam or with the Wave software, you can sometimes create your own templates, which is what I have here, kind of my starting point, my launching point. And so you can kind of select what you want in terms of your back optic zone diameter, your target power, and whatnot. With her, I did an HVID of about 90% of her overall iris diameter. And depending on which topographer I'm using to design my lenses, I will usually be somewhere between 90 and 95%. I sometimes feel like, because Pentacam measures horizontally, sometimes that's just a little bit, it's overestimating a little bit relative to what the vertical diameter would be. So if I'm using Pentacam, I usually go a little bit lower, like that 90%. Next, please. So this is what her scans looked like on the Pentacam, or on the Wave software. So just really, really typical looking. And we ordered this lens. It was kind of what the software spit out to us. And we had a beautiful fit. First lens right out of the gate. It was a freeform design, which I found was really good for her since she had that superior decentrate or that superior steepening of her cornea. So I have here her 1 day post Ortho-K subtractive map, and then I had another one that I had 3 months later, and you can see that that red ring has gotten a little bit more robust, but beautiful centration. We didn't have any problems with centration with her. Next, please. And here's her post-treatment data. Even after her very first night of wear, she was 20/20. And that goes back to why I like to measure that unaided acuity before we ever put a lens on their eye, because if you recall, she was 21/50. So then, of course, the next day, the parents come in and they watch her read the chart again, and they see that she's reading 20/20 after just a single night of wear. So that was pretty awesome. She still wasn't like over plus yet after that first night of wear, but you can see after 3 months, we were at a beautiful target for her. You can also see her axial length measurement over that 3-month time frame did not get longer. In fact, it got a little bit shorter, which just goes back to the choroidal thickening effect that you sometimes get with really successful myopia management. All right, so the next case that I would like to share with you all is a case of residual cylinder. This is a patient who has been doing Ortho-K since she was 10 years old. She started in 2018. And I had originally started her in a different lens design. You can see that she was a little bit higher myope with some astigmatism there. It's with the rules, so that's gonna be okay, but kind of a lot of cylinder. Next, please. Okay, thank you. So here's some of her data that is, remember, she's a current Ortho-K wearer, and she comes in and her unaided acuity is in her old lens design 20/20, and we're going to be talking about her right eye today. So you can see she's 20/20, but you can see that she has about a diopter still of uncorrected cylinder. And for doctors who do a lot of Ortho-K, you'll see that. You'll see a lot of times you don't get rid of all of that astigmatism, but a lot of times it's not much of a problem. And sometimes it just kind of bleeds in from that peripheral, mid-peripheral cornea, because we're fitting these treatment zones so small that sometimes that just bleeds in, but the patients are often very satisfied with their quality of vision depending on what their visual needs are. Next, please. Okay, so one thing that is really important to note though, even though the patient was 20/20, now that she's a little bit older and her visual demands have changed, she's saying that her vision declines throughout the day. So you can see we don't really have her overplussed anymore. And her sleep schedule's changed. She's not sleeping as many hours. She's also driving now. She's doing a lot more things at night where she's getting more fade, and she's driving with headlights coming at her, and that's a problem. Next, please. And so this is what her this is what her difference map looks like with her old lens design. And you can see that we just aren't doing a great job of totally pushing that cylinder out of the way. Next, please. And so I decided to change her into wave lenses. And I wanted to change her treatment zone. So when you're doing modifications in wave, you often will use the modification tool if you're changing the lens all the way around. The first wave lens I had on her didn't fully correct all of that residual cells. So I decided to do an oval treatment zone with her. And I have a little graphic down here. If you have with the rule, you really want your oval zone to be kind of oriented where it's longer horizontally. And if you have against the rule and you're making it oval, you would make it more like an upright. So in order to do that, hit the next button, please. You have to do these modifications slightly differently. That little white hash mark on the fluorescein map area up there that just the little circle is around it, that tells me which orientation I'm in or where I'm making that change. And that is consistent with the nasal part of the lens right there that you're changing. And you'll look down at the bottom there where the OC and the IC are. You always will change both of those because you want the difference in them to always stay at 0.6. And so if you change the IC, you have to change the OZ as well. And I'm changing the OZ and the IC because that is what is going to change the treatment zone size and make it an oval treatment zone. And when you're in modification mode, you have to switch that. It's always automatically at the all button, and you'll want to change it to either 1/2 or 1/4 to change it only in that one quadrant. I usually put it in half mode when I'm making these changes. And it will change it only in that quadrant, but also a little bit out of that quadrant as well, but not all the way over to the 90 degrees away from it. Next, please. And you can adjust how big of steps you're making by clicking the modification increments. It can be like 1x, 2x, 4x, 8x. Next, please. And so I changed it with her in just one meridian. Did it first nasal, and then I did it temporal. And you'll see when I look at the simulated fluorescein map, when I'm in the nasal and temporal, that reverse curve depth is different than the slide or the picture on your right, where when we're in the inferior and superior, you'll see that the depth of the treatment zone is much greater. And again, we still have that 0.6 differential between the IC and the OZ. So I wanted to show you what that oval treatment zone will look like on a difference map, and I wanted to include both Pentacam and placido-based topography in my presentation today, because I know some doctors have one and some doctors have the other, and it's nice to be familiar with both. But you can see on here that treatment zone, it's a much more beautiful dark blue ring, but it is flatter in one meridian and wider in the other, which gives us that oval treatment zone. Next, please. Is the fluorescein slide or the fluorescein pattern that you can see. When you do these oval treatment zones, if it's enough of a difference, you will actually be able to appreciate it a little bit on that fluorescein pattern when you put the lens on the eye. Next, please. And her post-treatment data, you can see that she was at the 1 month mark, she was +1/4. At her follow-up, and I think it was an afternoon follow-up, she didn't have any residuals still left, so it really worked beautifully. She was still 20/20, she was 20/20 before, but now she's a much happier 20/20. She's driving safely at night without us having to worry about her not seeing properly. And that's it for my presentation.
Thank you, Dr. Chapman. That was really great. Next up, we have Dr. Sindt.
Great. Hello. Thank you for having me, Dr. Chapman. That was fascinating. I don't do Ortho-K, but it makes me want to do Ortho-K. That's fantastic. So I would like to talk about sort of that whole diagnosis to dispense. So my practice is primarily sick and diseased corneas. And a lot of patients are sent to me for the diagnosis of what is going on with their eyes. So the AXL wave, the Pentacam is probably the most important piece of equipment that is in my practice as far as seeing the patient, diagnosing the patient, but just in my general clinic flow and patient flow overall. Next slide. Right. So we've been talking about fitting scleral lenses, and that's where I'm going to start this particular lecture. But the overall usage of the machine is very important too, and so we're going to get into that a little bit. But why profilometry? Well, we really want to fit the actual ocular shape, as Dr. Fadel was saying. My patients travel great distances to come to me, and I get consulted from people globally as well on how to fit them. And so really what we're doing is we are crowdsourcing information. We are crowdsourcing what we've learned, and we're crowdsourcing our mistakes. And by using profilometry, we can make adjustments based on the collective knowledge of the group, the collective knowledge of everybody out there. And so we're not alone when we do these fittings. Everybody can see what we're seeing, and then we can make those focal adjustments without changing the whole fit of the lens or the fall of the cards, right? We also improve the clinic flow. And so as I'm going to show you, when the patient comes in, I get all of their diagnostic testing done ahead of time. What this allows me to do is allows me to sit with the patient, really talk to them about what is going on, and then be able to fit the contact lens, whether we do it that day or whether we do it at some point in the future. I don't have to bring the patient back to do the contact lens fitting. This technology is all technician driven. So my day is really about connecting with the patient. My day is about making sure the patient understands and that we have a going forward plan. They don't really want me doing all of the detail work of collecting the data. Okay, so I'm going to introduce you to one of my patients, and I fit this patient a little over a year ago. So I've now been following him and monitoring him in his contact lenses that he's fit. So we have a lot of follow-up data on him as well. But this young man, 25 years old, he had this complaint of blurred vision and diplopia. He had a recent diagnosis of neurofibromatosis 1, and he was sent to rule out optic nerve lesions because he really felt that his vision was decreasing precipitously. And the neurologist said, you know, I think your eyes are dry. I don't think we don't have optic nerve lesions, but for dry eye, because of the dry eye reasons, I'm going to send you over to see Dr. Sindt to see if maybe a contact lens will help with the dryness. Okay, next slide. Now, when the patient enters the clinic, they get the technician will run the full sequence overview. Now, I want to break this down so you really understand how you can use this clinically. So it can act like your autorefractor. So you can get your baseline start to autorefract, but it also lets you see the aberrations inside the patient's eye. So in this case here, you see in the top row, you see the color map there. That is what that map is showing us, is that this patient suffers from a lot of coma. Coma is the predominant aberration in keratoconus. So when you see this map, you already understand that the patient sees everything spread out, halos and flare, you know, spread out vertically. The large coma and all aberrations are pupil size dependent. So the larger the pupil, the more aberrations the patient is going to get. This also gives you a baseline of where to start with your refractions. Now, in people with keratoconus, they actually have clusters of refractive points. So somebody could be a -14, but they could also be a -6. They could also be a -2 and see equally well at any of those points. So it's very important to get a lot of data on these patients, and using aberrometry data really helps you hone in on where most of the cluster of those points are. And it's generally going to give you a better refraction than if you kind of hunt for it during your regular refractive exam. The overall view also gives you this retro illumination view of the optics. It's going to tell you, do I have something on the cornea? Do I have scars? Do I have something obstructing the vision, such as a cataract? And in this case here, in that image in the middle row there, what you see here is that inferior area where it looks optically different, and that is the cone. And you can see where the cone is. You can see how much of the pupil is taken up by that cone. You can understand that there's going to be a different refraction through the cone versus around the cone, and this is going to help you understand the patient's optics and if glasses are possible, because sometimes glasses are possible. On the right hand in the middle of that, you see the axial eye length. This is going to help you with myopia control, but in this particular case, for this particular patient, he has a very long eye. And so you need to be thinking about things and pathologies that may be with patients that have very long eyes, such as lattice degeneration or the risk of retinal detachment. Also with this, you're going to know that patient's got a longer eye, that patient's going to be more myopic. And then we have the Scheimpflug tomography images, right? Not just the cornea is very important, but also the CSP maps, right? That peripheral profilometry. And these images, boom, 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 you can get all of this testing done in maybe about 5 minutes, 7 minutes with your technician. And so when you get into the exam room, you just have to pull it up and you review these tests with your patients. And it makes you look great. The patient can see all of these images, understand these images, understand what's going on with them, and the technology really puts you above other practices that they may have been to, because they really see you as forward thinking. Next slide, please. So in this particular patient, I got this 4 maps. I like to, as the other ladies showed tonight, I use the axial map, the pachymetry map, and the front and back elevation map. Now, the pretty picture map, I call that axial map the money map, because what I tell patients is the less green you have, the more money you cost. But it's not actually the map that I really look at for diagnosis of disease. The first thing I do is I look at that pachymetry map, that corneal thickness map. Those little rings, those are called isopacs, and I want to make sure that they're even, that they're in the center of the eye. I follow patients with corneal transplants this way because you can pick up local areas of edema, which may indicate that the graft is failing or you have a rejection episode. So you really want to look at those isopacs and make sure that they are centered and even. Anytime, in this particular patient has a very thick cornea, but I also look at the center, but also the thinnest local, and to see if this patient is potentially a candidate for collagen cross-linking. Going over to the elevation maps, I look at the front elevation map, but I think that posterior elevation map may be one of the most important maps that you can look at, because this is really going to tell us how much back bowing is on the cornea, how progressed is this disease, and what is the potential visual outcome for this patient based on higher order aberrations. So a lot of residual aberration that you're going to get is going to come from this posterior map. Now, if a patient has 100 microns or so, I tell the patient, you're probably not going to get perfect vision with just a contact lens, and we may have to look at an aberration controlled contact lens to get better vision. And I really like to look at the ectasia display, because it tells me, do I have keratoconus? Does this fall into the regular range? And this looks at the center versus the periphery, and how does it change in a pattern that is consistent with a normal eye or consistent with keratoconus. And then we have the CSP profile map. And as I mentioned, the AXL wave is very fast. It is very fast at taking these profilometry maps. And so I do that at the first visit when the patient checks in. I get information for that patient, and then I can even store it, right? So sometimes my first fit or my first meeting with the patient is really just talking about their disease. It's talking about setting up a care plan, or what I call a care map for the patient, so that we don't have to do everything all at once. They understand the process, they understand their insurance, they understand how much money it's going to cost, they can go home, they can talk about it, and then we can actually order the contact lens at some point in the future, because I already have their eyeball. I already have their shape, so I can design the lens without the patient sitting in my chair. I can design the lens at some future point and keep my clinic flowing during the day. Next map. All right, so the old way, now keep in mind, I have been fitting scleral contact lenses for almost 30 years. I've been fitting scleral lenses when scleral lenses were not popular. And so, back in the early 2000s, if I had this many fitting sets, I would have been super overjoyed. I think this would have been my happy place. I now, when I have to fit a contact lens using a fitting set, it just takes so much time, right? You have to put the lens on, it has to settle, the patient can't see, you have to promise them they will be able to see. It just takes too much time in your practice. It takes up a chair. It just takes up too much time in your practice. So profilometry really is the new way. You get better results with less time with the patient in your chair. All right. So again, I like to say I use profilometry because people are complicated, but your fit does not have to be. And this lets me spend more time with the complexity of the patient. What's going on? Are they potty training their puppy? All the things that the patient finds important, because they're just assume that the contact lens is going to fit. Okay, next slide. And so when you import this data into the ScanFit Pro, the Synergized ScanFit Pro product, next slide, it allows you to create a 3D elevation of the actual ocular surface. So you will see the eye in 3D space. Now, what elevation-specific technology is instead of using splines where you lift or you lower a spline, this actually creates a 3D mesh, we call it, which are these little tiny triangles. And every place one of those triangles intersects, you can actually grab the corner of the triangle and pull it up or pull it down. Now the software automatically does this for you. You have control over it, but you don't have to design every single point yourself. But what that does is it allows you to create not just what you think of a free-form design, but a completely overall for the whole surface, a complex geometrical design. Right. So how we do this is the software will automatically detect the limbus. So when you import the CSP map into the software, you actually create this 3D map of the eye, and you can see where the junction of the cornea and the limbus are. And the software will detect the limbus. So the contact lens is going to be whatever size the limbus is, that it fits it in, and it fits it out from there. From there, you create that back surface design. So you decide your central vault, the centration, the mid-peripheral clearance, the limbal clearance, and then you can choose to bump or anti-bump the periphery if you want to create extra clearance over an irregularity on the ocular surface. And all this automatically happens, but you do have control over it as well. So the software has this feature, it's called bumping, anti-bumping, or negative bumping. And so bumping is creating more clearance. Anti-bumping is creating less clearance, and negative bumping allows you to go in and just eliminate irregularities on the scan or on in the design that you don't actually want to have be there. Okay. Now, the interesting thing, and I said, you get bumps all over it, and I want you to see this particular case here, and it may be a little hard to see, but in the picture on the left, you're going to see right below that arrow, you're going to see a little bump right at the limbus. So this particular patient had a bump right at the limbus. In the lens design on the right, you're going to see that same bump shows up. It's right below that arrow line. You're going to see that same bump shows up in the lens design itself. And so this isn't an area where you create a spline and you have to lift up or lower a whole area. You can create a bump right around the actual bump on the ocular surface. So if you have a pinguicula, you can create a bump right around that pinguicula. But the software, the CSP software, picks it up, automatically imports it. You can create more or less if you desire. Next slide. And so then you can create your final design. You see it all in 3D space before you actually export it to the lathe to be made. Okay? You can make sure you have the clearance in the right places, the thickness, the limbus, the peripheral design, everything. Okay. So let's build the lens on this particular patient's eye. So you'll see in this particular patient, he's got something interesting going on that superior limbus. He's got some little pinguiculas. Okay. And then we put the CSP design right on the patient. Now in this particular patient, it's not a bitoric periphery. He's got some irregularities all over on that scleral landing haptic there. And his max to min in this particular case, as Dr. Fadel was pointing out, is about 150 microns. Go ahead. You design the lens in 3D space. You can put any optics you want on there. And then here's the lens fitting on the eye. Okay. So in this particular case, his baseline was 2060 and 2080. And he ended up 2020 in each eye. So it's very easy to put the cylinder or the extra optics that you have in these lenses. And I've been following him for about a year now, and he has stayed 20/20, and his eye has stayed white and quiet. Our next adventure with this young man is he does have a little bit of residual higher orders, and so we are going to play with putting the higher orders on this patient. So next slide. I guess that's it.
Thank you so much, Dr. Sindt. And our next presenter is Dr. Kuzniar. Take it away.
Thank you. And I just want to say everyone's cases were so great. I'm just really honored to be on this panel with these wonderful women that I've watched lectured for years and have really helped to shape my career on my own as well. So I'm here to talk to you about using actually the Keratograph. So in my office, a little backstory about myself, I just opened up a cold start a little bit over 6 months ago. So I have a brand new office. It's just me as the solo doctor. A Pentacam is definitely on my wish list, but right now I'm just using a Keratograph. But I've used the Keratograph for a number of years, and I think it's a really great tool for a lot of private practices, a lot of general practice with the dry eye treatments, and with issues with developing wave lenses. So I'm going to walk through a couple cases using the Keratograph. So the first one I want to talk about is actually designing a microvault scleral lens with my Keratograph. So this first case was a patient that was referred from an ophthalmologist. Luckily around me, I have a lot of great referral sources where these patients are already getting screened by Pentacams. And then they can often send those images over to me and then send the patient over to be fit in a scleral lens. So this patient in particular had a little bit of mild post-LASIK ectasia. So, looking at his eye, I used the Keratograph to get a general shape of his eye, to get his HVID, get a good starting point. And it doesn't look like too tricky of a fit at all. Go on to the next slide. So when I put the diagnostic lens on the patient's eye, everything looked great except for those two little tiny pinguiculas, which when I was first looking at the patient, they didn't seem like they'd be causing too much of a problem. But when that diagnostic lens was on and as it started to settle, I knew immediately that this was going to become an issue over time. If not in the first few weeks or few months, over the first few years, this is going to cause an issue with your patient that they might drop out of lenses because of redness and discomfort, or it might actually start to irritate that area. So the thing that I love about the Keratograph is it has this really great anterior segment camera tool. So it has this great camera so it can image, my bulbing glands, do dry eye testing. But I really started using it a lot to help me to design things like their microvault. So the first thing I did with this patient is I took a picture of their eyes and I showed it to them on day one. And I said, this is the only problem I'm anticipating with your scleral lens fit. You have these two areas right here. And unless I do something to design around it, you're going to have a lot of issues in the long term, and I don't want to cause harm to your eye. So what I did is I just pulled this up right in front of them. I love being able to actually, take into account where exactly is that lesion, look at the rotation of where I need to, design that microvault compared to their toric haptic, and I can actually measure how big of an area I need to vault over that pinguicula. If you're looking at something like depth, you can always use your anterior segment OCT, or you can take a good guesstimate sometimes. Of course, if you have a Pentacam and the CSP, you can design this right into the lens, and that's fantastic. I don't have that capability in my practice, and I think a lot of doctors, starting out or in private practice might not have it right away either. So this is a really great tool. And it's interesting how many offices I go into for scleral lens workshops, and they have a Keratograph, and they don't even know that this tool is there. So really just kind of play around with your Keratograph. But I love using this anterior segment camera tools, and I just measure exactly, where do I want that microvault? How do I want it? And if you go to the next slide, you can see, if you look really super closely, the microvault's going to have those three little dots, which is actually a ripple that I designed into the edge of the lens. So for this patient, he got down to 20/20 vision, and the lens was comfortable, and it was the very first lens, and he took it home and he was able to wear it long term. He never had any issues with redness or compression of that pinguicula. So for this, this patient was so loyal, for coming to me as a cold start. He immediately, put Google reviews, put me on Nextdoor, brought his wife in who also got fit into scleral lenses. So using some of this higher technology, just like the other speakers have mentioned, it really just puts your practice at the next level. And even just doing something like using an anterior segment camera, that alone really wows your patients, and it's made really loyal patients to me. I have patients that I fit in a microvault lens that drive 2-3 hours because they've moved, and other offices might not have the capability to design such a lens, and they'll travel back to you because it's the only lens that they've been comfortable in. So the next case that I do want to talk about is actually an Ortho-K lens. So I wanted to do a little bit of both. So in my office, I do a lot more scleral lenses, but I also do Ortho-K. So the case that I thought was a little bit interesting was a patient with high myopia. So I don't know if any of you that fit Ortho-K have ever fit yourself in Ortho-K, but let me tell you, as someone who is a high myope, that first 1 to 2 weeks is kind of awful, okay? So in the past, and this was years ago when I was fit with just traditional Ortho-K lenses, I'm going from a -6, trying to get down to plano, taking 1 to 2 weeks, having that initial period where you're at -2, a -4, the lens is shifting. It's kind of awful. And so it's interesting seeing that from firsthand. You know, I don't want my patients to go through that. So this patient was a 9-year-old patient that was referred in to me because he was having increasing myopia. So he had went from a 475 to a 575 in just 1 year at 9 years old. Let's go on the next slide for me. So what I did was I decided to design a night lens. So just like Dr. Chapman mentioned, I have my own presets for my night lenses based on using the Keratograph. So anytime I'm doing myopia management, I like to set my optic zone at a 5.5 millimeters. So that's what I did for this patient here. And I love just being able to pull up the maps for the parents in the room and show them, you know, this is your child's eye. I'm custom designing a lens for them that's going to help them to see really well right away. So I start with that 5.5 millimeter optic zone. For the diameter, just like Dr. Chapman said, I like it to be 90 to 95% of the patient's HVID. One little pearl that I am going to share with you if you do have a Keratograph. So if you notice, one thing that's different between my designs and hers is I actually have to design in a lot more edge lift for my lenses. So the reason behind that is because the Pentacam will measure a true like white to white measurement. With the Keratograph, it measures, but it kind of extrapolates the data a little bit more once you get towards the limbus. So what I found is if I designed a lens how I would initially want it to look, those edges were a little bit tight. So a tip I'd like to share for everyone with the Keratograph, I choose to make my presetting so that it has an edge lift of 30 microns, and that has helped my lenses to fit so well. If you're doing something like a corneal lens, which I also love doing on wave, I actually put that at 40 microns. So when I designed this lens and I dispensed it, I did a 3-day follow-up. So the patient went from a -575 down to a -0.5. So the reason I do a 3-day follow-up, this has always been like a talking point for Ortho-K. I find that after 1 day, it's kind of hard to judge exactly how your treatment's going to look. What I choose to do for my patients is I will dispense the lenses on Friday for children, have them wear that lens over the weekend and come in on Monday. So that way, as they're learning a new lens and they're struggling with their parents, you know, at bedtime in the morning, they're learning that over the weekend. Also, if their vision is fluctuating the first couple days, it's fluctuating on a weekend where they're not trying to look at things like the board at school. So by the 3rd day, he came in on Monday morning. He was seeing 20/30, 20/25, which was even better than his glasses. So he was ecstatic. And then next slide for me. And then the other thing I always want to point out as well is using your comparison maps of your pre-treatment versus your post-treatment. What this is really going to show you is, you know, what exactly am I doing with the eye? You know, it actually simulates it and puts it on the patient's eye in the photo just to show this is the treatment zone. It's centered. It's exactly how I want it to look. At a 10-day follow-up, so a week after his first follow-up, the patient was still doing really well. His refraction was only a -0.5, a -75. This was a little bit later in the day, in the afternoon, so I anticipate that happening for the first couple weeks, like I said. The other thing I want to look at too is just making sure that peripheral blur is still within the pupil. So we don't want that treatment zone to be as wide as possible like it would be for an adult. We still want that blurred circle a little bit into the pupil, not where it's going to be causing them vision issues, but enough so that we can still get that good myopia control. And then at the month follow-up, I like to do a 3-map comparison. So there's a lot going on with this slide here. So the main maps that I like to look at is the one actually on the top right, which is going to be your difference map. So that's going to show you from, you know, pre-treatment to where you're at right now. So looking at that, I have a nice centered treatment. That middle map in the top middle, it always looks a little bit messy because you're comparing like 3 different treatments. But basically what that's showing me is that the treatment is still being centered, but it's showing me that the treatment is getting a little bit bigger as time goes on, which we expect to happen as well. And then next slide. I also like to look at the refractive map as well to show me exactly how much am I treating to make sure you're not over treating your patient as well. So if you're looking at the refractive map going from baseline to the 1-month point, I know it's really hard to see with those little tiny numbers, but I am getting a true like -550 to a -6 diopters of correction for the patient. So in conclusion, my patient ended up at 20/20 minus. I always feel like there's a little bit of minus just because of that peripheral blur. The lenses were centered, the treatment zones were centered. The patient was super happy. I thought it was so funny that he came to his 1 week follow-up. He was like a brand new little man at 9 years old. He had a brand new haircut. You can just tell his confidence level was so high. And I just have loved using the wave lenses for my patients since I opened up my new office. I've had 100% first lens success for all of my patients. So that just gives confidence to the parents that, you know, they're investing all of this money and time into their child. They want a lens that's going to work right away. They don't want you to have to keep coming back over and over and changing the lenses over and over for their child. We want it to work well, we want it to work fast, and we want it to, you know, manage their myopia.
This was such an insightful presentation. We really want to thank you ladies for your time and your expertise. For any listeners, if you missed any part of the webinar, you want to watch it again, you'll receive a link to the recording next week. And again, if we didn't get a chance to get to your questions, we can answer them via email. And that's all the time we have for tonight. Again, thank you everyone for watching. All right, have a great night. Thank you so much.
Thank you.
Thanks, everyone.
Bye.